All right, good afternoon to everyone. If you would go ahead and place your name and campus in the chat, ensure that your screen name shows that as your name is as it is on the roster. Ensure that you are not in those prohibited places like a vehicle, hospital, those different places. As always, these sessions are recorded and they are viewed by the attendance administrators. In the event that you cannot be in front of the camera, just put a message in the chat to myself. Don't send it out to everyone. Sometimes you have to step away and use the restroom or just step away to do something real quick. Just put a message in the chat to myself. So we'll have a record as why you're not on camera. Welcome to is this week 8? Welcome to week 8. Hopefully everyone is doing well. Our little time here is winding on down, you all. So let's see, week 8. So homework grades are still on. So after class tonight, I'll turn those off. So give you one last glance, but just keep in mind, what the rule is about the 78% outright without rounding for both homework and key graded assignments to be valid and to count. Let's see here. We'll pull up our schedule here. So are you all out Wednesday and Thursday and Friday or just Thursday and Friday? Let's see, modules.
Thursday and Friday.
Okay. All right, so the week is almost over for you all. Let's see here.
Wednesday too.
Wednesday also. Okay. It's Thursday and Friday. All right. All right. So let's look and see where we're at and where we are going. As I initially said, after that first exam, to me, time just goes. I know it's the same time, but it moves by pretty quickly. So we're in week 8 now. So we have all of our required readings. You do have your adaptive quiz and your lesson activities. Next week, we do have unit exam 3. And officially, we finish all of our coursework, our concepts this week. So we have an exam next week. And then, we spend our time going back through information. So we're prepping for the HESI. All HESIs are in week 11. For those of you that have more than one class, start thinking about what that's going to look like for you. And it is campus specific. So start asking those questions of your campus dean as, deemed necessary. For this exam, in the event if you think you need a proctor, please go ahead and send an email at least 72 hours prior to the date of the exam to your campus dean, myself, and Dean Brown, asking for that request so that a place and a person can be in place for you. But again, HESIs are week 11. For those of you that are taking more than one class, just keep in mind that all HESIs are given that week. It is campus specific. It might not necessarily be the time of your class. So keep that in mind. Be looking at your schedules and see what you need to rearrange, put on pause, or do differently that week. And go ahead and have whatever conversations you need to have. And then week 12, we do meet briefly for attendance. And just so that we can, just talk. We usually look at the stats for the HESI exam, and we just meet briefly during that week. All right, here, let's see here. And let's see, something else. Oh, the exam review schedule. Let me show that to you. Here we go. So it starts on tomorrow. Let's see here. Dr. Tenza's is tomorrow at 7. And then Professor Foster's is Wednesday, and then mine is Saturday. So at a minimum, and this is all in your under the announcement section. I just pulled them here, but just at a minimum, commit if you can't attend either. Hopefully you can, but if you can't, commit to at least going and viewing them because that we do see whether or not you looked at them or not. So put those on your schedule as well. So we will take our breaks like we did at the end of every hour. And then at the end, we'll give you a little bit more time to get together as your groups to talk about, revise, do those last minute touches because we're almost there. Week 10 is the week we present. All right, so let's look
When
here.
will we be able to register for the HESI?
So it's campus specific. I don't have that information. You have to send that email to your campus dean, and everybody's different. So go ahead and start that conversation. With this is week 8. They're week 11. They usually start sending out information. They usually start around 9ish into 10ish week, but you can go ahead and start the conversation with your campus dean. Is campus specific. Yeah, I will go ahead and start the conversation at least when we get back from at least next week when we get back from the holidays.
Deandra says she's in the waiting room.
I've clicked admit. Yeah, sometimes it just take a little while to get in, but yeah, I've clicked it for to come in. So again, it is campus specific. So don't rely on what someone is saying about what their campus is doing. So reach out to that campus dean yourself to see what is required of you, and when can you start that process. Like I said, for sure, no later than the end of next week. Usually, put it like that. Usually, because it's campus specific, and so those is whatever those deans decide. We just encourage, just remind you all that it is campus specific and to reach out to them early. Okay, let's see here. All right, so we're going to look at our different nursing theories here. And then we have our interactive activity, and then we'll do the groups at the end. So that's kind of how we're going to do it. So just wait on this to pull up here. Our document is still processing. I need to close it and reopen it. Well, these are week 11. Make sure that for all of your courses that you're going back for week 1 to week 1, looking at that content, because remember, it is going to be compilation of all of it. And you just never know how they'll ask the question, but if you understand the concept, then you're more likely to be able to respond correctly. So just make sure that you're going back to week 1 and looking at all of that information, making note of those concepts that still really don't have a good understanding of, because those are the concepts that you want to spend more time with. So start by looking at that of your recordings, your required readings, because remember, you're going towards the HESI, which for that you have to look back at all your courses. So just start looking at that information. Okay, it's open now. Let's look at these different theories. Now these theories, they guide how we start looking at information, how we want to take information and actually look at it. We come up with the thought, well, person that has diabetes, do they have pain? How should we look at this? Is that an issue? Is that something that we should be looking at? And if so, what's going to guide us in how we interact with the participants, how we get the information, what we do with the information? We usually go back to these theories, these different theories. So there are numerous of them. There are 3 concepts important to nursing. Of course, the person, where does that person sit in that theory? Is it based on their belief? Is it based on them doing something or them not doing something? No, what is it about this person? Do we go to the person? The person comes to where the healthcare is. What is it about that person? And then the health. What is the goal of nursing? And then the environment. You know, is it home? Are we creating, or do they have to come into a clinic to get this information? Are we taking it to the people? There are several different projects and interventions that we can implement on the job. You could be that occupational nurse. It could be in the skilled nursing facility. There's so many different settings. So Florence Nightingale was the first nursing theorist, and she emphasized environment being that huge piece of a person being as well as they could be. So cleanliness was a huge thing, because we know that there were so many increased rates of infection. So environment, what is the ventilation? Does it matter if this person is hot or cold? Do we need to adjust the temperature in this room? A lot of facilities have it where, no matter what the temperature is that one temperature. But then there are some facilities that have it where the rooms have their own heat and warmth, so that person can control that. Does noise, does that make a difference? We talked about situations. If a person is in pain, they're hearing noise, they hear all these alarms and things going off, and you're trying to go in and gather information to do your head to toe assessment, they're probably going to be non-compliant. So we want to silence the alarms, answer their alarms, make sure we silence them, and then we're more likely for that person to be um, responsive to us, because if they don't, even with the noise, they might even hear and understand what you're trying to, communicate to them. And then what is the lighting? You wouldn't think that blinds being up or down would affect someone's response, but it could. You could be trying to show them something and asking them to read, because you're trying to assess their visual acuity, and they might can't see it because of the glare. And the light may be too bright for them. So all of these things, that environment, Florence Nightingale says, and then of course cleanliness, keeping those hands washed and clean. If we do a sterile procedure, it's the honor system. If we break sterility, it's on us to say, hey, broken sterility, I need to discard these supplies and I need to start all over again. And so we do know that is the difference between someone getting an infection and they could end up dying as a result of getting that infection. So, often spoken as the first nursing theorist, Florence Nightingale, she felt strongly that environmental issues influence the course of the illness. So just think about the last time that you or a loved one was in a healthcare setting. How was that environment? Were things cluttered? Were things nice and neat? Was hand washing or hand sanitation stations, were they readily available? And if they weren't, how did that make you feel? Or did your family members say, hey, don't go back there again? It was, cluttered, or it wasn't clean. So the environment, it does play a huge part in our care. So we have Abraham Maslow, hierarchy of needs. We always go with airway, breathing, and circulation. Then we move on over to Uncle Maslow. Even though it's at the bottom, it's that foundation from which all the other parts of us actually stand upon. So those physiological needs, food, shelter, and then we go up and down that hierarchy. In the event that a person, they're talking about a storm is coming, I think tomorrow night. In the event that storm leads to someone not having shelter, then, that's going to be more important than, socialization and things like that. If that storm comes and it leads to someone not having running water, then that becomes more important. So Maslow, the common needs are arranged on that hierarchy. Unmet needs create tension, which motivates the person to react to meet the need. And the example that I just gave indicates this bullet point right here. That unmet need, no running water. I'm going to try to seek, a place where there is running water, or there is the roof is gone up. I'm going to seek shelter. So that unmet needs creates tension. And so it motivates a person to react and try to get that need met. Now, if I try to get shelter, there might not be a shelter. There might not be someone home, like a family member home that I could go to. But nevertheless, it creates me to try to meet that need. When needs are met, the person is no longer aware of the need, and the need not met, now met, no longer motivates him or her. So once I've gotten shelter, I got food, water, shelter, clothing, then, it's relief. And that's not tension anymore. That need is met. So dominates needs that matter to a person can vary in life. It could be that, a storm could have not come through, but it's okay that I live with a relative. That's not high on my list at that moment in time, and that's okay. But essentially, if you think about it, that need is met for me, even though it may not be my dwelling. it's okay for me to live with someone else. So that dominant needs that matter to a person can vary in life. So it just depends. That might not be something that's important for me right now to be up under my roof, whatever that roof is. Um, but it might be okay, depends on what my mindset is to be, to be within that family home, live with the family, and so that is okay. We support them in it. So we have ORM, the self-care deficit. In general, this theory does have these three sub theories: self-care, self-care deficit, and then the nursing system. So self-care, goal that is directed toward a safer environment for life, health, and well-being. And then the self-care deficit, personal care does not meet the therapeutic self-care needs. Can I take care of myself? So we have to think about that. We do. I know you probably have met patients that, hey, I'm ready to go home, but then they're not just ready, just had surgery, their physical therapy still working with them, but they're ready to go at that moment, but they're not ready yet because they can't meet the needs that they need in order to be self-sufficient. And so we do need, Orem said we need to think about that. And if they do go home, are there going to be resources and people in place so that those unmet needs are going to be taken care of by someone else? So nursing systems, nurses empower the client through their interpersonal relationships to help meet their self-care demands. We talked about establishing those therapeutic relationships early on, so that in the event that something happens, that our patients, they're forthcoming to tell us information. They're not apprehensive about sharing, the good, bad, and the ugly with us. So that is important. So Leninger, her big thing is culture, incorporating and understanding about a person's culture and incorporating that into the interventions, into that client's care. Identified two kinds of care in every culture: generic and professional care. Generic meaning home remedies used in care. It's important that we find those things out to see, what have they been doing to take care of themselves, and what have been their outcomes. Has it worked? And if it's not anything that's deemed as harmful, a lot of times the healthcare providers will include those in their care. They will actually write orders for different home remedies. Professional care provided by people who are specifically trained to provide the care, the nurses, the occupational therapists, the list goes on and on. So literature proposed three modes to guide nursing decisions when providing care: cultural care, preservation, and then maintenance. Let me just make sure we're recording. Yes, we're recording. Okay. And then cultural care, accommodations or negotiations. Cultural care, repatterning or restructuring. So in the event that whatever that remedy is, or that intervention, that thing that that patient was doing, if it's harmful to them, we want to repattern. We want to offer information so that they can change out that behavior to something that is not harmful to them. So that's what this repattering or restructuring is. Like I said, but in the event that whatever these remedies are and it's okay, it's not causing them any harm, is in fact helping them. It could be, home remedies are, there are an array of those. Some people, cut up lemons in the water just so they can get, it entices their appetite to drink more water. But then if this patient is on fluid restrictions, then we want to repattern them, get them to understand or at least explain, reinforce, why it is important to limit the fluid intake. So then they may want to lay off the lemons in the water because, in fact, that extra water or fluid intake is going to be harmful to them. So we want to repattern or restructure that intervention that they're actually doing. But we do want to preserve those things that, that are not harmful. And Lindra said that's important because it's the patient that's receiving the care anyways, right? And so they do have the right to refuse. We do want to support their autonomy, whatever decision they make, but we do want to make sure that they have enough information so they can make that informed decision. Okay, so Pavlov's interpersonal relations theory. A basis for developing a therapeutic relationship with the client. The relationship that is developed has certain parameters and is the major part of the treatment. So we've got these four phases. So the orientation seeks out assistance because of a felt need. The identification understands the situation and responds. And then exploitation begins to depend on the nurse and then uses the help offered. So, the patient comes in, they know, hey, I need to be here, and that's the first step is them coming in and accepting, seeking out assistance for whatever it is, learning how to do, monitor that blood pressure, learning how to manipulate that cuff so they can do those blood pressure measurements or finger sticks. Some may even have to do self-catheterizations, whatever it is, they seek out that assistance. And then they begin to understand the situation, after several conversations, information is exchanged and they start to ask those questions. And then here in this phase, they begin to depend on the nurse and use the help offer. At first, it's like, okay, I'm just here, because I'm supposed to be here. But then during the exploitation phase, they start to use that information. They start to ask more questions. They start to say, hey, watch me do it. Tell me if I'm doing anything wrong. And, watch my steps. Did I clean my finger off right? Did I put the blood pressure cuff on right? You know, and then during the resolution stage, the dependent behavior must now be given up as a therapeutic relationship ends. So as people clip their wings, they're good. They have an understanding of what it is that's expected, the blood pressure measurements, the glucose, the self-catheterization, whatever it is. And they've had all of their questions answered and they're ready to fly solo. They're independent with that task. So we let them that the relationship usually ends because we answered all questions and they have that understanding and they're able to manage whatever the disease process is. That's that third level, tertiary care. So Rosenstock, health belief theory. What is that person's belief? We can have interventions beautifully written. We can have equipment lined up. But if that patient does not believe that those interventions, those things that we're going to do is necessary, if they're not wanted, then those are just beautiful interventions and supplies that we have. Because Rosenstock says, hey, we need to find out, what does this patient believe? What do they know about the disease process or whatever it is that's going on with them? What do they know about this upcoming surgery? Do they believe that this is something necessary? So trying to explain why a person will or won't take action to prevent or detected illness. It is rare that a person doesn't want to have that best quality of life. We need to try to seek out, well, what is it? Make sure they have all of the information, and then we still support them in their autonomy, whatever they end up deciding, either to accept the intervention or decline. Perceptions vary. It may have no basis in reality. It might just be something that they just decide they believe that's not necessary. And as long as we have given them all of the information that they need to make an informed decision, it is okay. Beliefs are connected to existing barriers. Sometimes, a lot of times, my belief in going forward to accept an intervention or not is based on those barriers that I've encountered. Yes, I want to go see the specialist, but I don't have the transportation to travel 100 miles away. I don't have the means of taking off a day from work, just to travel. It's gonna cost me money because I need to pay someone to take me. And also once I get there, I might be underinsured. I might not have any insurance. And so based on those different barriers, and sometimes people just are so comfortable with their healthcare providers, their primaries, they're like, okay, I'll just let them take care of whatever it is. I don't need to see that other person. So whatever that belief is connected to whether or not they'll move forward with those interventions. Acute to action is seen as necessary. So what is that patient's belief? And we honor that. So Roy's theory, she's is based on adaptation. Describes the recipient of care, the client as a holistic adaptive system. And this is another reason why, we do next gen and select all that apply, because it's rarely that you have one person with one thing that's, wrong or going on with them. So we need to think about the entire person. We need to consider the age, whether or not it's male or female. We need to consider, if they're insured, uninsured. There's so many pieces to that of taking care and deciding what is best for that patient. So both internal and external stimuli affect the system. Okay, identifies the types of stimuli as focal, referring to something direct, such as the client experiencing pain. Contextual, meaning other factors that affect the focal stimuli, like being examined in the area of pain. And then residual, referring to both internal and external factors that may not always be evident. It may not be obvious as to what's really the issue is. Okay, and then coping mechanisms. We have a regulated subsystem, refers to the internal effects that take place in response to what is happening internally. And then the cognitive subsystem refers to learning, processing, judging, and emotion that the client uses to cope with what has happened, that adaptation, coping, pivoting, all those words, that means that person's adapting. And then we have Watson's, the human care. Health is harmony among the body, mind, and spirit, involves self-perception and how the self is experienced. Illness is lack of harmony within the self and the soul. So you want to include that. It's kind of like a more of a holistic approach too with Watson, because you're considering more than just that illness. You're considering, what is this person thinking? Are they really wanting this care? And we're including their spirit as well. We're thinking about what is that spirit part of that person? What does that mean to them? Is that a religion, or is that just a relationship? What is that? But we're including that in that person's care as we come up with interventions for them. The nurse's role is a caring process to help the client regain harmony and health. And so as you continue with your education in nursing, you'll go back on, you'll reach out to not reach out, but you'll look back at the different theories and see if one of those theories guides or is related to whatever your intervention is that you're trying to do. So what we're trying to do is a nursing research. So you identify specific nursing interventions that are proven effective and not merely based on tradition. So then you consider your population, that intervention that you're trying to implement, and then you go back to one of those theories that we just went through and see if it matches. And it usually falls under one of those theories. You're going to usually have one, and that will guide your practice, and you'll consider what those theories say is needed in order for your intervention to be effective. So nursing research provides evidence that supports the quality and cost effectiveness of what we do as nurses, and we generate knowledge for clinical practice, nursing education, and delivery of nursing services. So this is evidence-based information. This is how we're doing things. This is why we're doing things the way that we're doing them. What's the 2-step method? How we know that it needs to be a 4-step method of checking the blood pressure? How do we know the different landmarks, identifying where to give the injections? It's generating that knowledge. It's coming from the research. So we have 2 different kinds. We have quantitative and qualitative. Okay. So quantitative is an objective study. A variable is the event the researcher is trying to measure. So quantity is measurement. So think about all those things that we can measure: height, weight. Even if someone's getting an EKG done, that's a measurement of their electrical activity. Think about if someone is getting spirometry done. That's that breathing test. It tells us how well those lungs is a measurement of how good those lungs are functioning. What about drawing blood? What about a finger stick? You're getting a glucose measurement. You're getting the red blood cell count, hemoglobin A1C. Even if you were doing echocardiograms, you're getting that measurement of that function of that heart. So those examples of quantitative. Even measuring height and weight, that's a quantity. So then qualitative, we usually get the information through interviews. Now, these can be done in one-on-one interviews, or they can be semi-structured with the person that's doing the interview, you, the nurse, and then the different participants. And it's just based on whatever your question is or what information you're trying to find out is who your audience is. So if you're trying to find out about diabetes and pain in females, then your audience could be, persons, the females that have diabetes, whichever type, and those that have pain. It would not be those that did not say that they had pain. But qualitative, we usually gain the information, and it can be given in the form of a survey. It could be a sit down talk, and the talk, of course, is recorded. It could be one-on-one interviews, and from that information, things are identified. We interviewed 30 people, or we gave this questionnaire to 30 people, and 20 of them said that they have back pain, and 10 said that they have all these different kinds of pain. So even though it's a different way, it's qualitative information, it's voices, it's words, is their interpretation, it's still gathered evidence, and it's just considered as qualitative. A case study examined the lived experiences of high school students who are both gifted and diagnosed with attention deficit disorder. So it's information that's gained, it's words, information that's given, is qualitative. No matter if it's an interview, if it's a one-on-one, or sometimes they call them focus groups where they'll sit with several people. But it's qualitative. That's qualitative versus quantitative. Quantitative is a measurement, and then qualitative, we gain information through words, whether it's written or oral. So evidence-based practice, Dr. Cochrane, a British epidemiologist, challenged the public to pay only for medical care that was proven to be effective. He advocated for the use of randomized controlled trials, and you probably have heard of these, as a means of reliably informing healthcare practice. So just randomly doing it rather than specifically picking out. The Cochrane collaboration was established to prepare and promote the accessibility of the Cochrane Reviews, a collection of evidence-based healthcare interventions. So this is information that we can look back and say, well, the evidence, we look back at the questionnaires where they said, we had 1,000 people, 10,000 people we did EKGs on, and the evidence shows that, majority of them were normal. The other percent were abnormal, and they were male, but the evidence shows. So evidence-based practice. In 1999, the Institutes of Medicine issued the report urging to build a safer healthcare system, which discussed the incidence of medical errors. And so this is where, it hadn't been that long ago, because this is just 2025, where they began to effect a change where they were mandated electronic health records. And then I don't know if you all have seen some of the electronic medical health records, but I think I told you all a couple of weeks back where now they have it where it turns different colors if it's due, so that person can remember, the nurse can remember, hey, we need to give this medication, because it's a medication error to administer medication outside of the time frame. You usually have the hour before, the hour after. That's your time frame. So if medication is administered before or after that, then it's a medication error. Some facilities have it where if the client has orders in, all of their 8 o'clock, we're just going to say 8 a.m. medications, come already prepackaged. So it saves time, and they say it lessens the error where the nurse didn't have to take the time to empty each pill out of a box or a bottle, or either punch it off a card. The only thing with that is, if an order changes, then you have those if the pharmacy isn't readily available, excuse me, you have those prepackaged pills already. So it's going to be on that nurse to go in. And I don't know if you all have seen those prepackaged, but it gives you like a description. It'll say blue pill, oval shape, and it may give you a little bit more description, but it's not like looking at a bottle. Well, this bottle says Tylenol 325. We know what's in this bottle. Have you all seen some of those prepackaged? Have you all been in a facility that has those where they're already prepackaged? No, no one has. Okay. And I think a lot of facilities are kind of going away from it because, like I said, if one order changes and they've already in pharmacies not really available, then it's on that nurse to realize that that order has changed. Then they have to identify that pill that's in this and just imagine a person take 9 pills or 5 pills at one time. So all 5 pills is in this little package. And on the package, it has a description of the pill. It doesn't say, because on medicine, it rarely has the name of the pill stamped on the pill. So, but nevertheless, they have all these things in place where it should lessen medical errors. And how many medication rights are we up to now? Is it 8 or 9 medication rights before we administer medications?
I've seen varying, but I've seen them around like 6 to 9.
Yes. And so that was my point, Rochelle, was that initially it wasn't the 8 or 9, it was just 6. But now, since we realize, that all these medication errors have happened, they added all these measures in to help, and also to let the patient decide. The right to refuse wasn't one of them, but now it is. And so as we learn more, we have a better understanding, then things they're revised or reformed. Okay. And so in 2001, the Institute of Medicine issued Crossing the Quality Chasm, a new healthcare system in the 21st century, calling for consistent, high quality healthcare for all people. Included was patients should receive care based on the best available scientific knowledge. And so that pushed facilities to, get the latest equipment, to revise their policies and procedures. There was this push. And why not? If we have this information that that's evidence that says, hey, these patients can have better outcomes by doing these steps. Why wouldn't we want that for our patients? Why wouldn't we want that for ourselves? And so that's what the push was for. During the last 2 decades, insurance companies began to pay for healthcare practices only if their effectiveness is supported by the scientific evidence. So then in some facilities, nurses, one of their tasks is, and some that's their sole task, they go back in and they look at the documentation, the nurses' notes, they look at the lab results, they look at the medications that were ordered, and they see if what they call those. Is it core measures? I know y'all probably have seen them. It's usually in the hospital where you see them more at, where the individual nurse, that's solely their job. They're scanning charts, they're looking at everything, and they leave these notes and say, hey, you didn't do this right here. And what they're saying is, not that they're not only following the policy procedure, but the policy procedure that's based on the scientific evidence. And so it brings that healthcare provider back full circle, say, hey, this person came in complaining of this. You missed ordering aspirin for them, or we missed this right here. We need to make, and after so long, then they'll get in, the motion of making sure they, at least if they don't order something, they address it in the documentation that says why they're foregoing that treatment. Because there are instances where what's evidence-based may not be the best for that patient in their circumstances at that time, but the documentation should reflect why, to support why they did not, because that's where you get into, well, if the person has, if the person decides to take their information to a lawyer, remember that nurse expert is going to look at the charts, going to look at the policies and procedures, going to look at the documentation, what happened and what should have happened. So if that nurse expert looks at the documentation and sees why something wasn't done, and the explanation was there, then more than likely that it will not move forward, because there's an explanation as to why the norm, so to speak, the scientific evidence wasn't followed through. And there are some instances, people have, we're providing that unique care anyway. So we should consider what disease processes that patient has going on. If they have, everyone has different, some people have different allergies. So we surely would, even if it's evidence-based, we're not going to give someone a medication just because it's evidence-based and we know that they have a known allergy to it. So, but that documentation should support why that healthcare provider did not follow the evidence. So during the last decade, hospitals are denied payment when complications in Medicare clients develop and evidence-based guidelines are not followed. So this, and I know you all probably have heard this in clinical, and maybe even some of you all that work in healthcare facilities. Patient goes in, they go in for, we'll just say pneumonia. The patient ends up falling and breaking a leg or hip or something. So those complications are not related to why that patient went into that hospital. So that healthcare facility absorbs all of that cost because it's not related. So, and even if they submit it, they're denied payment because they say this patient came in for pneumonia. Why did we not keep this person from falling? And so, of course, if we have documentation that shows, hey, we lowered the bed, put the bed on the floor, we had mats, sitter, went through all of these different things to prevent this patient from falling and injuring themselves, then payment might be, reimbursed. But you got to have that documentation, that proof. And putting in Foley catheters, that's another reason. Another kind of people have kind of shied away from those unless they're just absolutely necessary because it's so easy to break that sterility, and it's an honor system for that nurse to stop and go get new supplies if sterility is broken. So in the event that client is just having that Foley catheter put in just to have a procedure done, and then they end up with a urinary tract infection, sometimes insurance companies, they don't pay. They're like, well, hey, what happened? This person, this is a procedure that's sterile. They shouldn't have a urinary tract infection. We're not going to pay for these medications to treat this urinary tract infection because it's unrelated to why this patient came in. So clients and families are seeking the latest evidence on websites about most effective treatment and illnesses and diseases. And that's good that they're seeking out information and adding to their knowledge base. And then therefore they can have questions and their questions can be answered. Okay, how best evidence for practice guidelines is determined. There's a question that's investigated. Is there a connection with someone that has diabetes and pain? Is there a connection with height and osteoporosis? Just what is a question that's investigated. We use professional resources, the latest, most relevant research evidence that pertains to that question. So we look up and read articles and information about height and osteoporosis. Is there any information out there on this? To see if there's any correlation. An expert or panel of experts conducts a systematic review, which is a summary of the results of the selected study. So then they go in and say, okay, well, this is a summary. Is this information, is it valid? Is it related? Or, is this a good clinical question or not? So using critical thinking skills to gather evidence is combined with the clinical experience and the client's preferences and values for use in a specific clinical situation. So the elements includes the best research evidence, the nurse's clinical expertise, and then the client's preferences. We want to include the client in there because they're the ones that are receiving the care. So the nurse's role, the nurse has many different roles, and this slide is just showing all the different levels of education here. The question the basis of the nursing action by considering research, evidence, tradition, and client practices. We're just not haphazardly just pulling things out of the air. The evidence, the research is guiding those things that we do. We want to, once you probably have the opportunity now to join your state nurses organization, and they have usually have access, you will have unlimited access to all the latest information, articles, and they have webinars and all of that on, different topics. Excuse me, the spirit of inquiry. This is usually the new nurses, we see this usually all the time, but Not to say that the seasoned nurses, we don't have it, but is the spirit of inquiry is just saying, hey, I know we're doing this procedure, but can we do this procedure using less supplies, less steps, less time, less resources, any of those, a combination of those, is challenging the traditional or existing practices. The spirit of inquiry is not a bad thing. It's trying to determine, can we do this? Get this client to have better results. If at least the same, if not better results in doing it different. That's all that spirit of inquiry is. It raises questions and it challenges the existing, what we are currently doing. Okay. All right. We just got a few more minutes before we at the top of our first hour here. Let me go ahead and pull up any questions about those theories. And like I say, no matter what, you can go back, you can match it to at least one of those, if not two of them. But they are really, really, they were onto something. They're really, really thought it through, even um even if the patient, it's so important that we determine if this client believes in this intervention. When we come in there, hey, do they really want this done? And it can mean it's really that the person is not being non-compliant. It might not just be important to them, might not be of value to them. So we would need to go and get some more interventions. So that's why we want to make sure that we're providing that individualized, unique care for our clients. We want to establish those therapeutic relationships up front because they'll let you know, hey, I don't like this, or this is how I think it should go, or this is what I've been doing. So at least you would know what they have, what they understand, and what they've been doing. So evidence-based practice involves the integration of three key elements: the best current evidence, clinical practice, and client preferences. We don't want to use outdated traditions. And usually the clinical guidelines, they're supposed to be updated and revised as things are updated. So using clinical guidelines, research findings, and including clients' input ensures that the care is safe, current, and individualized. So best current evidence, clinical expertise, and then we want to make sure that we're considering the client preferences. So the research design, I don't think we touched on that, but the research design is crucial in determining the study's validity. Like, is this study valid or not? It impacts the study's ability to control the bias, and which is a key factor in determining whether or not this study is it a good study or not. So is this study valid, the validity, that research design? So what would you think would be a barrier to implementing evidence-based practice? What would the nurse have to do initially if they were in, what would they have to do? What would be a barrier?
Understand cultural differences.
Say that again, I'm sorry.
I said understand cultural differences.
Okay. And then what does it take to find out the cultural differences? What would be what all of that would fall up under what? Taking the blank to find out.
Assessment.
So what do we have to do to get the assessment? What is going to take what? A certain amount of what? Time. Usually time is the issue in finding out all of this information about our client. And it's kind of perceived as a barrier. I don't have time. I don't have time to go in there and talk to the patient. I just need to answer these questions, and I need to come on out of it. I need to do this. So, and it's a simple thing, yet it's not simple. The lack of time is frequently given as a barrier to implementing evidence-based practices. Um, you know, we kind of struggle to find time to go and sit and have that conversation. Not really sit, but interact with our clients to see what their cultural beliefs are. That time. And some states do have like the nurse patient ratio, some don't. It's whatever the facility deems. How is it worded? Whatever the facility deems it didn't say appropriate, but it kind of means that same thing. But that time piece that we have to spend with the client to find out, to do the head to toe assessment, to find out more about what their beliefs are. Have they used any home remedy? It takes time to go in and talk to and to gather that information from our clients. And so we talked about that question, and that slide didn't go into formulating a PICO question. That question considers what is the population? Like the example that I gave about the diabetes and pain. We were the population were male and female, but they had to have diabetes and they had to experience pain. What is the intervention? What are we offering as an intervention for them? What are we supposed to do? And then you're going to have that comparison. So whatever the intervention is, we do have to have some of them that do not receive the intervention so we can compare. And then what's the outcome? So formulating that PICO question, it includes population, intervention, comparison, and outcome. That is going to be that first step in that evidence-based process. And that helps to clearly define the clinical problem, and it guides our literature searches. So then we go into the literature and we search. After we formulate that PICO question, we identify who our population is. The other example I gave, we're talking about females that are 5'5" to 6 foot that also have the diagnosis of osteoporosis. So that's our population. What's our intervention? Chair exercises, comparison. We have to give those. We have to ask some to not to do the chair exercises and some to. And then what's the outcome of that? Did we see what's going to be the measurement? Did their bone density tests, were the measurements better? So we formulate that PICO question: population, intervention, comparison, and the outcome. That's going to be that first step in the evidence-based process. And that helps us to clearly define the clinical problem and guides our literature search. Then we go to the literature and we look up, hey, occurrences of osteoporosis in females. Are there any occurrences of osteoporosis in males? Because you want to see if there's any other things out there that we have not considered. And so, but the PICO, so that you all understand what I was talking about when I said PICO, we're formulating that question, and that question consists of those parts. You know how we say SMART goals, you have to have the S, the M, the AR, and the T. So the PICO, in order to create that question in research, you have to have the population, the intervention, the comparison, and the outcome. And what were those three parts that the three key elements for evidence-based practice? What do we say they were? We want to consider what the client's preferences are. Clinical, we want to have the clinical expertise, and then the current evidence. We don't want to be doing things that are, outdated, so to speak. Any questions so far? Okay. So what is the regulatory agency that links hospital reimbursement? Who are those people? So who pays? They're twins. And
Can you repeat it?
So for hospital reimbursement, who are those big two entities that play that key role in linking hospital reimbursement, like getting paid for the services that they provide? Not the candy, but I guess those are bad hints. So the Centers for Medicare and Medicaid Services, they are part of the United States Department of Health and Human Services, and they play a key role in linking hospital reimbursements to care quality. They go back and look and see, hey, did we provide? Remember, I told you that nurse that goes around and I think it's quality measures. They look at the chart and see a person comes in with chest pain, and they look at the chart and see what were the orders. This patient get aspirin? Did they get? Was it a time frame where they were supposed to be receiving the clot buster? Were they taken to the cath lab? And if they were not, was it documentation that says why they did not receive those things? So the Centers for Medicare and Medicaid Services, the CMS, they're part of the Health and Human Services. They play that key role in linking hospital reimbursement, how the hospital gets paid, to the care, the quality of care that's provided. And how do they do that? They look in the chart. They see what the patient's outcomes were. Through the value-based purchasing initiative, the CMS, the Centers for Medicaid and Medicare, they financially reward hospitals that meet or exceed performance measures. I don't know if you've paid attention to, like, they'll have signs posted. We what's one of the latest signs that I've seen? We're number 3 or number 2, or we're number 1. Have you all seen like those signs at hospitals, or it may be on their websites or whatever? But they're saying that they met or exceeded the performance measures. And so that includes clinical outcomes, that includes infection control. That means they more than likely had low infection rates. It means that their clients, when they did those patient satisfaction scores, that more likely that the patients gave them good marks. You know how when you go to Walmart or the Dollar General and they ask you that little survey at the end? That's a nurse's task. In some places, that's what they do. They go around and they do one-on-one with the patients. Hey, the nurse that came in today, did you see them wash their hands? How satisfied upon discharge? How satisfied were you with your care? And they go through this questionnaire thing. And so based on those patient satisfaction scores, the infection rates or the infection control rates, the clinical outcomes, the patient went in for some type of surgery. They didn't have any falls. Their fall rates are low. Their pneumonia rates are low. Their UTI rates are low. And the UTIs that they have is the reason why the person came in is not related to, they can't relate it to the nurse doing a procedure, breaking sterility. So what they say is that, and this is a real thing, hospitals are rewarded because it says that they have met or exceeded the performance measures. And I don't know if you all have been in any of the break rooms too at the hospitals. A lot of times they have like those little charts on the wall, and they have the little bar graphs, and they show, how well that unit is doing. And it goes back to the CMS. They're linking it to reimbursement. They're saying that, hey, you all are doing well, so we will pay you, for the services, the acquisitions that you're sending in, because your staff is performing well. And that's how it is right now. This approach promotes accountability. They say it promotes accountability, though, and how taxpayer funded healthcare facilities are delivered. So it's kind of like, they say it kind of like pushes everyone to do well, to take the time to wash your hands, to take the time to be assertive and not aggressive, and to take the time to get, if your client has questions, to seek out opportunities of who can answer those questions, even if we can't. And so that comes from the Centers of Medicare and Medicaid. Was that clear, or do I need to go back over Medicaid and Medicare and that hospital reimbursement of what they look at? Okay, hearing no questions. So we will pause and go to our first break. So I will see you all in 5. Remember, this recording is still on, you all. You can turn your camera off and mute yourselves. Okay, I'm waiting on this activity to load in your Canvas mail. Give me just a moment. Let me try to load it again. Okay, it's attaching. Let's see if it's gonna go out. Okay, so hit refresh if you are already in your Canvas mail. There's a mail I just sent. This just says activity. And I think there's about 11 slides. And what we're going to do is just randomly put you in groups unless you just talk about the questions that are on the slide. It's all the things that we went over just to make sure we to identify if we still have questions about anything. So let me go ahead and open up the breakout room. This is just a random group. This is not your group project. So you go into your Canvas mail, look for the activity that I just sent. It may say activity 8 or might just say activity. Give you a few minutes to work through those slides and we'll bring back and talk together in whole group. Let me open up the breakout rooms. Okay. So go to your Canvas mail, look for the activity that I just sent. Will take a few minutes to give you time to work through and talk through those slides. And this is not your group 10. This is not that. This is just randomly putting you in a group with someone. Miss Tuggle, are you there? Did you receive the invitation to go to the group?
I was in a group, but it just put me back in here.
Okay, let's see.
I don't know what happened. Cause I was in there with Vernisha, but I don't know what happened.
Marissa, are you there? Okay, did you all find the activity in your Canvas mail?
Yeah, it's loading.
Okay, just talk. Were you all able to find the activity in your, were you all able to find the activity in your Canvas mail?
No, it's saying the lesson.
No, it's in your Canvas mail. It says it's like you got a mail from me. Email.
Yeah, and then it says download. And when you download it, it says there's a problem loading this lesson.
It's just a PowerPoint slide. I think it has about 10 slides to it. Are you able to click refresh?
Yeah, I refreshed it. I went out and I went back in. Let me do it again.
Okay.
And where we at now? Number 5?
Number 5, yes.
Slide 5.
Okay. Let's see.
3. Balls, modifying.
It's the
It is
orientation.
orientation.
It is the orientation phase, though.
All right.
Orientation, identification, resolution.
It's only because it said, I don't know, it was something about the way it was worded. I think it was like seeking help. That's what I
It says
thought.
seeking help.
Yeah.
And the nurse gathers information to understand the patient's health concerns and needs. And then resolution, the patient needs are met and the relationship ends as the patient.
In healthcare evidence.
For number 12, information that's
I said, why did you choose? We agree on like for number 1. What did we say? Did we say B or C? Somebody chose C. I was trying to figure out what made them like what was their reason for choosing C.
Yeah, because I chose D. Someone else chose C.
I also chose D. Oh. So would it be E?
For 14? Yeah, I think it's all of them.
Yeah, combining these.
I'm gonna try to use this wheel. It's a bunch of back and forth though, but we'll try it. There are only, was it 10 slides? So we shouldn't take up too much. Let's see. Okay, I think we have everyone back now. Let me spin the wheel. I hope this little wheel works. We'll see. Spin. Okay, were there anybody in group 9? Let's see. Nobody was in 9. Spin it again. There were 10 groups, but there were 2 groups no one was in. So group 10, let's see. Thomas, Cedrina, and Bowling. Let's see. What question do you have? Let's see. Let me go. Hold on. Let me stop sharing. Question number 1. Let me share it on the screen. Okay. Which 3 components are considered foundational in nursing theories. What did you all come up with?
We put D.
Okay. Assessment, intervention, and evaluation.
Yeah, I
Where
had thought C, though.
we want to
I had
edit
said C.
C. We want to include that person in there. Remember Nightingale, what was her thing? The environment, making sure it was clean, it's well ventilated. But we always want to include that person in. So if you think about it, assessment is going to come from the person, which all of these things right here does. But those three concepts that are considered foundational, as Nightingale, you got to include that person. We got to see what's going on with them, and then that environment. If that environment is dirty, it's not clean, if it's too hot, even if it's too much noise, it's not conducive to that person healing. Okay. All right, let me spin the wheel again. Let's see here.
Wait, so what do you say?
The answer was person, health, and environment.
Okay.
Mhm. Let's go. Okay, let me show you the wheel. Okay, let's see. Who was group number 6? Was anybody in group 6? That was Stallings and Rochester. Let's see.
We had Florence Nightingale for that answer.
All right, let's see what we have. So, who is recognized as the first nursing theorist, emphasizing the importance of the environment in the patient care? Okay.
A.
Yes, it was Nightingale. So, what was Watson, Leninger, and Orm? So, just taking tip, you can either know it outright or know some of the others and do process of elimination. Okay. All right, so let me spin the wheel again. The next question is, in Orm's theory, what is the term for when a person's personal care does not meet therapeutic self-care demands? Let me see who's going to help us answer this one. No one was in team. Oh yeah, team was you all just answer. Let's pick another group. Group 8, Rivers, Burris, and Terry. Let's go back to the slide. Question number 3. In Orm's theory, what is the term for when a person's personal care does not meet therapeutic self-care needs?
I think I'm not sure what we agreed on. I'm thinking it was 3. I meant C, but I don't know if that's what we had agreed on.
Is
So
that what you are?
we agreed on B. I think we was trying to explain why it wasn't self-care deficient. But that one I think we agreed on B. But it could have been A, so I don't know.
So does not meet self-care. So which of these matches does not meet self-care?
C,
Self-care
right?
deficit. Exactly. So some questions are posed, and it's not a trick. Does not meet therapeutic self-care demands. So which of these means the same thing as that self-care deficit? But that's what Orm is wanting us to consider. This person had those 3 things. This person might not be able to, got that patient say, I'm ready to go home, but they hadn't even gotten up and taken the first steps after surgery yet. But they're emphatically ready to go home, but they're not ready just yet to take care of themselves or even to manage their care. Okay. Okay, let's go back to our little wheel here. Let's see who's going to do the next one. Okay, let's see. Do we have anybody in group 3? 3 was Powell and Murray. Let's look at the next slide. Okay. Which mode in Lineager's, I'm sharing now, theory involves modifying cultural practices to ensure safety and protection? Do we see anything that matches? Modifying cultural, because remember, lineage is all about culture. We do want to incorporate people's cultural beliefs, and what they believe in, and maybe some of their home remedies and things. But this says modify it. So we're having to modify it. Which of these? What are we doing?
Was it A?
Why would it be A?
Repatterning, restructuring.
Exactly. It means the same thing as
Yeah.
modifying it. And then it said to ensure safety. So remember I talked about, people have home remedies, but remember the example that I gave you was the fluid restrictions. Persons put lemon in their water so they can drink more water, but we don't, if they're on fluid restrictions, consuming over that amount, whatever that recommended amount is going to be harmful to that person. And it could be fluid restrictions. It could be, I don't know, some people, what's another one that's common? They put the cream inside of their nose. You have all different types of cultural practices, but the question says to ensure safety. So that means that whatever they're doing must not be safe, because we want to ensure safety. So we want to modify it. So we do want them to repattern. We want them to change, select something else so that it is safe for them. Okay, good. Okay. So the next question is Mr. Paplos, interpersonal relations theory. Which phase involves the client seeking help and recognizing the problem? Let me see. We spin the wheel so we can share the love. Okay, we didn't have anyone in group 1. Okay, did we do group 7 already? 7 is Tuggle and Norman. Taylor and Marissa. Let's see. Go back to the slide. So which phase involves the client seeking help and recognizing the problem?
Professor, I was in group 7.
No, I didn't say you, Deshay. I said, who did that say?
She was in the group with me.
Togo and Norman.
And I kept bouncing it kept putting me group 9, and I don't even know what other group I was in.
Okay.
It kept bouncing me in and out of groups.
But did you all make it to this slide?
Again.
So the 3 of you all, did you all
Yeah,
make it to this
yeah, I
slide?
did.
Okay, what did you all
Yeah.
come up with?
C, orientation.
Orientation. Do we agree the other 2?
Yeah.
Mm-hmm.
Okay. So yeah, we talked about them, realizing, that's a huge step, and people, you just think about us. Sometimes we think we don't need any help, but us seeking out help and recognizing the problem, it's that orientation. It's like, oh, okay, the light bulb comes on. Okay, I need help. Let me seek out, because that's what they're here for. So good. Okay. So according to Rosenstock's health belief theory, what is the key reason people may not take action to prevent illness? Let me see. Let's try this wheel again. Okay, a group that it may not, hopefully it'll pick a group we hadn't called upon, because this wheel didn't take out the numbers. So group number 6, let's see. Did you all already go? Group number 6, let's see. Who was group number 6? It's showing me Stallings and Rochester. Okay. All right, so let's go over here to the slide here. According to Rosenstock, health belief theory, what is the key reason people may not take action to prevent illness?
B.
Okay. Okay. Perceptions may lack reality. So remember, test taking tip, these little words, it's 3 letters, but it may change what you're thinking. So it didn't ask, what was Rosenstock's health belief theory. It specifically asking you why this person may not take action, which still leads back to the health belief theory. Because if they don't perceive it as, beneficial to them, then hey, it's just a nice intervention you have. Okay, ma'am, go open the next door. Door, what's behind door number 2? Because if they don't believe it's anything that's beneficial, believe that it's beneficial to them, then it's just a nice intervention that you have. And you go back and you revise, you discuss it with the RN and come up with another intervention. Because, it just depends on what their beliefs are. And it may be, they may have to bring in like a dietitian, like they don't believe that, that consuming low salt or low carbs or whatever it is, diet is conducive to their, beneficial to their health. And you might have to bring that dietitian in. If they don't want to get up and walk after surgery, you might have to bring that physical therapist actually in to talk with them. And then the physical therapy aide comes in and then work with them. So just, you may have to bring in others, because if they don't believe that it's beneficial, then it's just, not to say that the intervention isn't good for them, but based on their reality and their understanding, it isn't something they believe that's good for them. So anyone, in Roy's application model, what terms describes direct factors such as pain affecting the client?
Is it C?
Okay. Is that our final answer? Focal stimuli, and you all are correct. Did I give you all number 8? Did I give you all 8? I gave you all, how many slides did you all have? Because I didn't give you all of them. Did y'all have this
We
one?
had 16.
Okay, well, we'll keep going. How does, and anyone can answer this, James Watson theory on human care defines health? What you all come up with?
B.
Harmony between body, mind, and spirit. Bringing that spirit in, that mind, because we focus so much on the body. Okay, this organ is not doing this. They're breathing, over the, the normal amount. The O2 sat is low. So sometimes we forget about the mind and the spirit. Watson says, hey, this is important in this person's healing process. Okay, which type of nursing research uses numeric data and statistics to measure variables and determine cause and effect relationships?
Okay.
Measure. Yes, numeric,
Quantitative.
Yes, that quantity. Remember those examples I gave: the height, the weight, drawing the blood,
Right.
and you get the blood results. The echo, you get that heart function. The heart's function at
I knew
50%
that.
is that quantity. Got it. Good. Okay. So what is the process called where experts summarize the results of the selected studies to determine best evidence for practice guidelines?
Meta-analysis.
Is that our final answer? A summary. That meta is all that raw data. And then but the key word in here was the summary, summarize the results. So that's that systematic review. They just kind of give you like a review of what it was. Okay. What is essential for evaluating the effectiveness of selected evidence-based practices in nursing? What is essential for evaluating effectiveness?
B.
Objective data gathering. Is that our final answer? All right. Did I skip one? Nope. Okay. In healthcare, evidence is based is best defined as which of the following? What is evidence? What's the definition of evidence?
Proof, right?
B.
Information that has been scrutinized and compared to increase credibility. Is that our final answer? What is the definition of evidence? Information that has been scrutinized and compared to increase credibility. It is that information that we've gathered, all of this information, it's the evidence. It has we have to have that comparison, that we give, they call it placebo, all of the people, everyone didn't get whatever the intervention is. We have it and we see, what was the effects in those, was it the same results in those that got the intervention, that didn't get the intervention? So it's that evidence, that information is gathered and is scrutinized, looked over, is reviewed to ensure that it is correct. Because we use that guides what we do in our day-to-day practice. Okay. Which are considered key attributes of high quality evidence in healthcare?
C.
Okay. Yes. Is it valid? Is this stuff, is it right? Should we really be doing this? Is this stuff reliable? And then can we replicate it? So yes, that's good. Okay. Did you all have this one? I don't think I included this one on there. Did I?
Yeah.
F.
Okay, so we said F. Okay, evidence-based nursing practice involves which of the following approaches? Okay, you all said F. So we're saying combining research-based information, combining nursing theory, and combining clinical expertise. We don't want to apply treatments based on tradition. Okay, you all were correct. Nope, we don't want to do it based on tradition. We want to do it based on the latest evidence. Good, 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 good. Okay. Which type of quantitative research is considered the gold standard in minimizing bias?
D.
D.
Those blind studies. Got it. Good, good. So what matches minimizing bias? That will help us, with those blind studies. Okay, I think this is the last one. Which statement accurately describes systematic reviews in healthcare research?
B. The first B.
B.
Got it. Systematic reviews combine multiple studies using structured method. And this research you out, and it's really, it's the premise, it's the foundation, is why we're doing what we're doing. You all didn't have this one, I know. If I did, I didn't mean to give you this one. Okay, so we're gonna stop there. All right. So what we're gonna do is pause and take our second break, and we'll see you in 5. When we come back, we'll do the groups, our 10-week group. Remember, this recording is still playing. So mute yourselves and turn your videos off. We'll see you in 5. All right, come on back in. We'll go to our groups, and then and these are your 10-week groups. So make sure you're revising, putting those finishing touches on whatever needs to be touched up. Talking about whatever those challenges are that you've met, and what's the solution to them. So talking through those last minute things and getting that all done. So I'm going to open up the breakout rooms, accept the invitation. I'll look back at it one more time. I think I get everybody in the correct group. So this is your 10-week group. Talking through your last minute things, tying up loose ends so we can have that finished product. Ms. Smith, are you there? Did you get the invitation to go to your breakout room? This is your 10-week group. It didn't pop up. Okay, let me see. Can I send it back to you? Rochester's on her way. Just give her another minute or so. She's on her way.
Okay.
I told them that you were coming. So do you still have the invitation in to go, or do I need to send it back out? Okay, it went away. Okay, let me see if I send it back out. Let's see. Okay, yeah, you're in group 5. Let's see. Move to 1.
Thank you.
You're welcome. Move to 5. Okay, here we go. Uh-oh. Okay, so I'm gonna put you in 4, then I'm gonna move you to 5, I think. Some type of delay. Okay, move to 5. Okay. Okay.
So I guess once we start do the reference page.
Quality care benefits both individual patients and population. It focuses on achieving desired health results and requires adherence to the up-to-date professional standards. Core measures are used to track how often hospitals provide recommended evidence-based care to patients with specific conditions. They help ensure that patients receive high quality, standardized care based on the available evidence. The OBRA of 1987 significantly reformed long-term care by requiring comprehensive resident assessments, such as minimum data sets, also known as MDSs. And as a nurse, you can be an MDS coordinator and you complete those assessments, and that is your task. As a nurse, that you can actually do that. So, but the OBRA of 1987 significantly reformed long-term care by requiring comprehensive resident assessments that are known as MDSs, minimum data sets, and emphasizes individualized resident-centered care. It also mandated increased staff training and quality assurance processes. And you may be on that QA team as well, the quality assurance team, where you find out, what are some processes that need to be strengthened or revised a little bit. It could be hand washing. We're seeing an increase in residents that have UTIs that in the bacteria is E. coli. So that means someone's wiping the incorrect way. So that quality assurance nurse will pull up that data and come up with a plan. The plan more than likely is having the staff to demonstrate, peritoneal care. While hourly rounded in medication timeframes, they are also important to nursing practice, but they're not specific. STEEP is the acronym that we will talk about. We've talked about. It's STEEEP. The S it stands for safe. It ensures care avoids injury or harm to patients, which is fundamental for quality care. T for timely, reduces delays in receiving care to prevent complications and improve outcomes. Effective. So we got 3 E's: effective, efficient, equitable. So effective focuses on evidence-based care proven to yield positive health results. Efficient avoids wasting resources such as time, money, and supplies while delivering care. Equitable guarantees care quality is consistent regardless of race, gender, socioeconomic status, or location. And then P for patient-centered. It prioritizes individual patient preferences, needs, and values in all care decisions. So the PDSA cycle. So plan, do, study, and act. Plan. The team begins by identifying a problem, whatever that problem is. It could be high UTI rates, high fall rates. We have an increased number of people that are losing weight, but it identifies a problem and planning a specific intervention. What would be a specific intervention to decrease the fall rates, to decrease the number of UTIs, to decrease weight loss. And then do. The intervention is implemented in a small, focused way. It could be day shift, night shift for 3 days or 4 days, a week or so. And then study. Data is collected and reviewed to determine if the change made a difference. And then act. Based on the analysis, the intervention is either adopted more broadly, revised, or discontinued. So did this help? Do we need to change it up a little bit? Or it's just, we're going to discontinue. It didn't work at all. So that's that PDSA cycle. Quality improvement is an iterative process. It is the desired outcome. If the desired outcome isn't achieved in one cycle, the team should use the knowledge gained to modify their approach and then start that new cycle over. We talked about plan, we talked about do, study, and then act. If it didn't work, what information did we learn? What should we, is it something we need a whole new intervention? So you do need to know what each phase involves. And we just went in detail about what each phase actually involved. The Donna Bathan model refers to actions taken in giving and receiving care. Implementing examples of that is implementing, if we have a patient that's on that needs bowel and bladder training. So that means going in and offering that bedpan or assisting to the bathroom or bedside commode every hour to see if they have a schedule. I think that's just one example, but that Donald Bathan model refers to actions taken in giving and receiving care. Okay. So we have another acronym, Team STEEPS, is a program designed to improve teamwork and communication in healthcare. We're on a team, we're on that healthcare team, and it's imperative that we work together to so that we can improve patient care. And so the Agency for Healthcare Research and Quality, they actually created that Team STEEPS in collaboration with the Department of Defense. That program aims to enhance patient safety through better team performance. It aligns so that there's no gaps in care, so that there's no overuse or underuse. QSEN aims to prepare future nurses with quality and safety competencies. It defines essential knowledge, skills, and attitudes for nursing practice. QSEN focuses on 6 core components: patient-centered care, teamwork and collaboration, evidence-based practice, quality improvement, safety, and informatics. These competencies are designed to improve patient outcomes and healthcare quality. The National Quality Forum is a not-for-profit organization, and this focuses on quality measurement. It serves as a central repository for scientifically sound healthcare measures. So it houses all of that information. The NQF has endorsed over 500 measures that we use across healthcare facilities. They put their stamp of approval on it. These are okay to use. These measures are used to improve quality of care and support public reporting. Official government agencies, they focus on disease prevention and wellness that are appropriate for communities, that are appropriate for ages. The National League of Nursing aims to lead in setting standards that advance excellence in nursing education. The goals applies to all levels of nursing education, from the LPN to the doctoral programs. The organization develops models and competencies to guide nursing education. The National League of Nursing, or the NLN, focuses is on meeting the needs of nursing educators and advancing national health. The whole thing is improving, setting those standards and improving the healthcare that is provided, equipping us as nurses with the information and the skill set to provide that best care for our clients. Professional development is something that, and you might be the nurse that work with the professional development team, but it's something that we do ongoing. Like I said, we are life learners, so we're always trying to validate what we know, make sure that we know everything, and that we have the latest information. So, professional development can include unit-based trainings. It could be that a lot of facilities have it where they send the trainings to you do one-on-one. They send it to your account, your email account. But nevertheless, we will always be doing trainings and updates. And these trainings, they often address current issues and skills relevant to our specific clinical area. And yet there are some trainings that are going to be specific to, for example, if you work on med-surg or if you on OB or Peds, that are going to be specific to those areas. But nevertheless, it creates and equips us with the knowledge and the skill set so we can provide that best care possible. Frequent engagement in learning activities, it reinforces that knowledge and skills. Sometimes you, as that nurse, if you're on that professional development team, you might be the one that's leading the discussion. Sometimes they have video, sometimes they have person, but nevertheless, there's ongoing training and education. A personal development plan shows proactive engagement in professional growth. And so you will probably, as one of your classes, you probably have developed a professional development plan, but it allows for specific measurable goals for career advancement. This approach encourages self-reflection and continuous improvement. It demonstrates a long-term commitment to enhancing our professional competence. Medicare is a federal program primarily for people aged 65 and older and certain disabled individuals, offering hospital, medical, and optional prescription drug coverage. Medicaid is a joint federal and state program providing health care coverage for low-income individuals, including families and children, and covers some long-term care services. Medicare does not cover long-term custodial care. Medicaid may cover depending on the eligibility. Eligibility for Medicaid is income-based, which Medicare eligibility is primarily age or disability based. Medicaid is the primary payer for long-term care services for those with limited income and assets. Medicare does not cover long-term custodial care, as we said initially. So Medicare has a value-based purchasing program. It's similar to what we mentioned earlier. What it does is it uses selected clinical processes or care measures, including things like infection rates, falls, to assess and determine the reimbursement, that pay reimbursement. So everything matters. I mean, in the event that we see this person's at risk for falls, we need to implement those fall precautions. A discussion needs to be had. We need that care plan so that we can implement those fall precautions, because we want to prevent not only about the pay source getting that facility getting back reimbursed, but we don't want that person to fall, because we know falls and infections, they lead to so many other things. And it could be a lot on a person. So, at the minimum, don't want people to have harm caused to them. So we do want to implement those things that we should. Hand washing, using hand sanitizer, good hand hygiene. The Affordable Care Act initially intended to mandate Medicaid expansion nationwide. However, a 2012 Supreme Court ruling in Independent Business upheld this constitutionality of the individual mandate, but ruled that the federal government could not require states to expand in Medicaid. And so while that expansion was made available to states so that more people could receive the services, it was up to that state's government to decide whether or not they would subscribe or receive those funds from the federal government. There were not that many states that did not accept that expansion, because most people think mindset was like, well, let me just, help my people. And so expanding that Medicaid made healthcare more accessible and affordable for people. So they were able to go and get the preventative exams that they needed, and also the exams that were needed to manage their care. As a result, Medicaid expansion became optional for states. So that state's government didn't have to accept it. This decision has led to various Medicaid coverage, different variations of it across the country. Okay, let's see. Just a few more minutes and we'll bring you all back out. Let me see, what group were you in, Norman? Let's see. I think you were in group number 3. You were with Martin Murray. Okay. 3, move to 3. Three more minutes and we'll wrap it up. So while we said that Medicaid was income-based and Medicare generally takes care of the 65 and older, Medicare also covered some certain disabilities like the chronic kidney disease. So therefore you have some people that actually have, they're dual eligible. They're eligible for both. And so and that is, a service that is provided for them. Medicare is again a federal program primarily for people that are age 65 and older and that have certain certain disabilities. And so it offers Medicare includes hospital care, medical, and optional prescription drug coverage. Medicaid is a joint federal and state program, like we just said. Some states did not want to expand Medicaid. So those funds were made available from the federal government, but that's each state had to decide whether or not they want to accept those funds or not. Medicaid is a joint federal and state program providing health coverage for low-income individuals, including families and children, and covers some long-term care services. Medicaid is the primary payer for long-term care services for those that have limited income. The state's Children Health Insurance Program, also called CHIP, it aims to bridge the gap for children and families that earn too much money to qualify for Medicaid, but cannot afford the private insurance. So there's like this gray area. Even if you make $1 over that amount, you don't qualify. So they have CHIP. It stands in the gap, and so it is there so that those children are still covered. And as a result of this decreased the number of children that did not have health insurance, that were not covered. It was a beautiful program. So allow those children to get those preventative services and regular routine care that they needed. Accountable care organizations are groups of healthcare providers that coordinate high quality, cost effective care for Medicare patients, especially in primary care. Their goal is to improve outcomes while reducing unnecessary spending. To achieve this, ACOs must promote evidence based practice and report data on quality costs. When they meet established benchmarks, they may receive a share of Medicare savings and contribute to improved care coordination for patients. The ACOs or accountable care organizations, they are required to use evidence-based information, medication, and that's just a requirement. Private health insurances, while designed to make healthcare models more affordable, have really contributed to the rise in healthcare costs. This is an ongoing discussion. The Affordable Care Act model mandates for employer purchases of insurance. This provision helped more Americans be able to have that healthcare insurance. The goal was to increase access to healthcare, not to cause a burden, but just to increase the number of people that could have healthcare coverage, and so that they would not be penalized for pre-existing conditions. Okay, breakout rooms are closing. Everyone should be back in just about 45 seconds. Okay, just a few more seconds and we should have about 30 seconds. So we should have everyone back. Okay. Hopefully you've made good use of your time. You revised things, you talked it through. I'm sure you had to revise some things. That's just how it is. But hopefully you've come up with a solution so that we are ready in week 10. Remember, on next week, we do have the last exam. The exam reviews take place Tuesday, Wednesday, and Saturday. If you can attend, at a minimum, please look at them. The recordings are provided. And I think that will, I don't see you have any more notes. That concludes our content for this week. And then of course we'll, end and we'll take our break right here at the end. So we enjoy your holidays, be safe, and we'll see you on next week.